So let's talk some common sense here for a minute. To take care of others, we must take care of ourselves, and add to that ourselves, we have to take care of each other as well. We are trained to see and react and respond and treat a whole bunch of medical conditions, traumatic conditions, cardiac arrest, you name it, we are prepped for it. What we don't always do a whole really good job at is taking care of ourselves in the process. This job can be stressful. This job can add a lot of mental and physical sort of stressors to your life. And if you don't do what you need to do to take care of you, I can assure you, the 2 years on your Cataldo promissory note will seem like the longest 2 years of your life. I've yet to be offered a sum of money that really would make me willing to make my entire life completely and totally abjectly miserable. And I keep that work-life balance by knowing that this can be a stressful vocation and this can be a job that puts you in a lot of unique and stressful situations. So I make sure that my home life is my home life and I enjoy the hell out of that. And when I'm at work, I'm at work. And those are two completely and separate, totally different things. You need to make sure that you continue to do the things that you need to do to take care of you. Otherwise, sooner rather than later, you get to a point where uh, it becomes difficult to respond to these medical emergencies and traumatic events that we're going to talk about. So wellness is just that. It is a complete and total look at your well-being. It's mental, it's physical, and it's social. There's going to be opportunity to work as many hours as humanly possible. Rob told you guys that on day one, I think it was, that this is a job where you can decide how much money you will or won't make. Don't live in your work uniform. Don't take up residence at a base and work all these crazy obscene hours. Yeah, the overtime is nice, but you need to still have some sort of outside input rather than just eat, sleep, and go to work. We can achieve that. We can have a work and home wellness, but you do have to pay attention to a couple of things. What do you think? When do you think your body operates the best?
When it's rested.
Yeah, when it's rested, that's one of them. So getting enough sleep. A lot of the times, and Tavuti proved that to me today, I operate under the theory of garbage in, garbage out. If you don't pay attention to what you're putting into your body sooner or later is going to fail to rise to the occasion. So get enough sleep, eat as best as you can. I know it's going to be very tempting when it's 2 o'clock in the morning and you're on a 24-hour shift to eat those gas station hot dogs, but pack a lunch, take care of yourself, feed your body good. Now, I clearly am not the picture of eating right and taking good care of yourself all the time, but I do some of the things that I know I need to do to make sure that I am physically and mentally capable. Wellness is going to start with healthy diet, some exercise if that's your thing, get enough sleep. If you smoke, you should quit. Don't do drugs. Don't drink too much, and take time to yourself. There is such a thing as just taking a step back and taking it easy for a minute. There's nothing wrong with that. So let's talk about the obvious here. That top bullet point right there. EMTs often work in stressful situations. I kind of joke about this all the time and say, welcome to the club of the abnormal. We put ourselves in situations that normal people do not. Normal people avoid the things that we see and do, like the plague. If in a stressful situation, if you can do nothing else, you'll hear me and you'll hear Matt and you'll hear some of the other guys say, be the duck. That's what this next thing is talking about. Your calm manner will calm the patient, family members, and bystanders. When people are freaking out, it is contagious, and don't be one to catch it. Have you ever seen a duck floating on top of a pond? Anybody? Ducks?
No,
Yes.
question.
All right.
Yeah, I know the analogy.
You know the analogy. Good. So, duck floating on top of the water looks like it's doing absolutely no work at all. And if you looked with an underwater camera, he is kicking like all get out just to keep afloat and just to keep moving on. Nobody sees that. Nobody knows that. When you're in a stressful situation, think of that. You know, nobody in the world blames us for, being under stress. It's sort of just what you do with that stress when you're working on it. So I know I mentioned it briefly, and we're going to talk about it in a little bit when we do the scene size up lecture, but you must focus on your personal safety. Scene safety, scene safety, scene safety. You are absolutely incapable of helping anyone if you turn yourself into a patient. There's a period at the end of that. I know I already mentioned that on top of now not being readily available to be of any assistance, we also put other providers, other responders in a situation where they now have to take a couple gambles maybe to get us out of a spot that we had put ourselves into. So what do you think we do if the scene's been determined to be either unsafe or questionable?
Wait until it's been made safe.
Yeah, just wait. Stage up the road, stage out in your ambulance. There's no harm, no foul in sitting in your truck and waiting to make sure that you aren't going to go walking through a door and get your hair parted with a baseball bat. There's nothing wrong with that. The safety of you, the safety of your partner are paramount. Those are the top two things when we talk personal safety. After that, everyone else, the patient included, comes in third. You need to make sure that you are not going to be turned into a patient. Our focus always should be on patient care. That is really the paramount, right? That's what we're there for. That's what we're responsible for. We are the people in charge when it comes to a medical call or a patient who has been involved in a trauma. They belong to us and we belong to them. So make sure that your focus never leaves scene safety and caring for your patient. Yes, there's going to be other things going on. Yes, there may be other forces at play a little bit between, other responders and, the fire department and police department wanting to clear and family members freaking out because somebody's having a heart attack or somebody's in cardiac arrest or somebody just got shot, stabbed, blown up, you name it. But we need to make sure we concentrate on the things that we can affect, and providing quality patient care is absolutely something that we can affect. Strategies for stress management. Everybody, I imagine, knows what it is that makes them the happiest. That is the way I manage stress. Go for a walk with my dog, go for a hike in the woods, hang out with my wife. Those are all things that I know that will take and make the most miserable of days better. Know yourself and know what you need to do to continue on being a healthy and happy person. Sometimes the people we work with get on our nerves. It is pretty easy, especially after a little bit of time, to change your partners, change your work hours, move to a different schedule. So maybe, you're not humping 911 calls in Chelsea for 48 hours a week on Thursday, Saturday overnight and just getting burnt out. If you're working a ton of overtime and you feel yourself really starting to have a difficult time managing work, managing life, don't work so much overtime for a couple of weeks. You'd be amazed at how much working just a 40-hour work week can sort of change your whole perception of what's going on. Changing your attitude is probably the most difficult of all of these, really. It's difficult to sort of take a step back and look at how you're perceiving a problem. But when all else fails, talk about it with somebody. There's no harm at all. There's absolutely no or shouldn't be any stigma around talking with your partners, your friends, your family, other coworkers, professionals. There are times where you need to seek the help of a qualified professional to deal with some of the stress that goes into being a first responder and putting yourself out at the tip of the spear when it comes to helping the public. Do not obsess over frustrating situations. You know what? I've told you guys already, we are people, not machines. If something doesn't really go your way, if some call makes you feel bad because maybe you feel like you could have done better, you could have done more, know that you are really the best of a bad situation. You know, even if you can't figure out what it is exactly that's wrong with this patient or can't figure out, exactly what to do in a given situation, it's it's just one of those things. Sometimes you'll walk into a call, your patient won't have any real definitive, hey, this is what's wrong with me, and it becomes sort of aggravating. I mean, you guys are going to have a wealth of that 1,500-page textbook over the next couple of weeks, and you think, you go out and you think, all right, I am prepped and ready. I know all of this stuff. I'm going to go out and do the best. And then you kind of come to realize that it doesn't always go like that. You can't change what you can't change. We're going to see a lot of the same people for a lot of the same things. And it becomes a bit of a sticking point for some providers. And really, all we can do is concentrate on delivering that high quality patient care. I love this next one. Try to adopt a philosophical outlook. That is really what I just said. Be the best of a bad situation. This is clearly not a good day for the patient when they have come to meet us professionally. So all we can do is what's best for them. And all we can try to do is what's going to make them as healthy and safe as we can. What do you think this next one means? Expand your social support system.
Family members, friends.
Yeah, family and friends. Throughout the years, if you do this job for long enough, and it really doesn't take a whole lot of time, you'll start to develop friends that are like only EMTs or only fire people or only police officers. Your circle of quote normal friends gets a little smaller, but your circle of both work friends / work family gets a bit bigger. Don't lose track of those friendships that you had before you became EMS folks. Sometimes they have the best ability that there is to hear what it is that we're going to tell them and talk about as far as work stressors and things like that, because they don't really have the insight. They're just going to listen, not offer any judgment, probably not even offer any solution. But it feels damn good to just be able to get some of that stuff off your chest and tell somebody who you know doesn't know.
I don't know
And
about you guys, not to interrupt you, but I don't know about you guys, but I feel like my family or my friends would be like, if I was ever talking about something that um happened at work that was kind of stressful or kind of like pretty traumatic situation, they would say, "Well, why do you do that job?" You know what I mean? Like, so I feel like I'm gonna get that a lot if I, you know what I mean, if I ever talked about it. So I think that's a good thing that that you kind of lean on each other as EMTs and police officers and firefighters, because some people don't understand why you do the job. And I think my family and friends, some of them would be like, "Well, I don't know why you're so upset. You didn't have to do this job." You know what I mean? So
yeah, but look at the other side of that question. And believe me, I get what you're saying. There's been plenty of times over the years where I've taken a step back and go, my goodness, why do I do this for a living? But when they ask you that question, they might be, really just asking, well, what the hell are you doing this to yourself for? And I completely understand that. But look at the other side of that coin and say, you know what? why did I get into this? And it'll help to sort of refocus that energy a little bit, because nobody gets into any field, especially a field in public safety, to think that, I want to turn myself into a just stressed, neurotic mess that smokes 2 packs of cigarettes a day and drinks like a fish.
Right.
People get into these fields because they want to help people. And yeah, that isn't always a great question. Like, why do you do that to yourself? And I get that. But rather than sort of the knee-jerk reaction of, you know what, that wasn't helpful, take a helpful bit from it, because there's help to be offered in anything that people have to say about what you do for work and why do you put yourself in those stressful situations, because it does kind of just focus you back in and bring you back into, you know what, yeah, why did I get into this? I got into this because it's a rewarding job. I got into this because it puts me in spots where I know that I can provide for people. I can help, 1 minute I can deliver a baby. The next minute I can help an old lady. On Thursday in November, I know I'm going to be able to carry Nana into her house so she can have another Thanksgiving with her family. So it sort of allows you to take a step back and look at the yin and the yang.
Yeah. Because I've already gotten it from people. They're like, "Are you crazy? Like, you're gonna be upset sometime. Like, a lot of the time." I'm like, "I'm not gonna be upset a lot of the time. I understand that it's a hard job, but I always try to think like what you just said, like the rewarding part of it."
And for the most part, the general public has absolutely no idea really what we do for a living. They see what they see on TV or even on the news when, we make the news because we had to respond to something just gigantic in scale and catastrophic. And yeah, those things suck. I'm not going to sit here and tell you that they don't, but it's not an everyday occurrence.
Hmm.
Most of your time is going to be spent sitting around waiting for something to happen. All right, well, 1 minute bringing somebody to their dialysis appointment. The next minute I'm bringing somebody to a doctor's appointment, and we're going to wait with that patient and then bring them back to the nursing home. And then after I drop somebody off at the nursing home, maybe we get a 911 hit. But even those are not always the big, like, cataclysmic emergency that everybody thinks that they are. It's not every single shift where you work 12 cardiac arrests and deliver 3 babies and, auto versus pedestrian every other call, or pedestrian versus train. Those are once in a while.
Right.
We already touched on this a little bit. Nutritious food, garbage in, garbage out. Feed yourself well. Regular exercise and relaxation. I take a bit more on the relaxation side than the regular exercise side. But if, going to the gym and working out is your thing, make time for it. Good sleep. You have to sleep, even, when the opportunity for overtime is there. If you've been out straight, or, they say you're coming off the back end of a 24 and they say, hey, you want to stay on for the day eve and work, another 16, which can happen in a pinch, especially on a 911 truck. Sometimes the answer to that question should be, you know what? I'm dogged. I'm going home. Disease prevention. Have regular checkups with your doctor, have regular vaccination schedules. If you haven't been vaccinated against things like hepatitis and flu, or had a TB test recently, which I think most of you guys will have from occupational health, keep in touch with your doctor. Let them know that you've made a career change, because now all you guys went from the realm of not working in EMS with sick people to now working in EMS with sick people. And your doc might suggest some additional vaccinations and checkups and things like that. We talked briefly yesterday when we did anatomy and physiology about the human body and the immune system's response to things identified as self versus not self. Infectious and communicable diseases are things that can be transmitted person to person. They are organisms that enter the body that the immune system isn't necessarily always able to fight off. We can also get things like rabies and things like that from other species. We want to take steps to minimize our risk. Everybody has gotten in the habit now, because it's mandatory, of wearing a mask and, washing your hands and doing all the stuff we know that we should have been doing to begin with. It shouldn't have taken a pandemic to get people to wash their hands, but apparently it did. Wear all of your recommended PPE, your personal protective equipment. That is just common sense. The adage, if it's wet and sticky and not yours, don't touch it, is great, because that kind of focuses you in on, keep those things, the icky, creepy crawlies that we want to operate under the premise that everybody's got one, and we'll keep ourselves safer. Because, the time to find out that, you're possibly exposing yourself to something isn't after you've been exposed and didn't protect yourself. Protection is an ounce of protection versus a pound of cure, because sometimes the cures for some of these things are nastier than the disease themselves. So we have a couple of different routes of transmission. We have direct contact with things like bloodborne pathogens. We have indirect contact. Indirect contact would be something like a needle stick. You accidentally got poked with a needle. Our airborne transmission, that would be if your patient were to sneeze or cough sort of like right in your face. Foodborne transmission would be something like eating contaminated food and getting hepatitis A. Or then we have vector-borne transmission, things like the plague from the Middle Ages was a vector-borne transmission from the fleas off of rats. Proper handling of bloodborne pathogens is what's going to keep you safe from them. Wear your PPE, clean the patient care environment. We want to make sure that we are, not working in a petri dish. So if you've had a particularly sort of nasty call and, there's blood or any other bodily fluid strewn about the back of your ambulance, go ahead and be out of service for a minute and take some time to take care of that. Some of the special circumstances we can talk about, we'll mention just what we with that indirect route of transmission, a needle stick. There are things in place that need to happen if you are ever to accidentally be poked with a dirty needle. Cataldo Ambulance and any other ambulance company that you would ever work for has a designated infection control officer. You would call that person immediately. You would report to a supervisor every bit as quickly, but it is something that can make sure that you are followed up, and to make sure that not only now are you going to do what's best for you, but Cataldo will also help you do what is best for you in any other place that you work. Same deal. In today's lab, we're going to have hand washing lab. Everybody's going to stand at the sink with warm, hot, soapy water and hum happy birthday twice while they wash their hands. Nobody, nothing, no reaction? Don't worry, we're not going to do that. Soap and water is the way we should be cleaning our hands. Yes, in a pinch, those hand sanitizers are great. But you know what they're not really good at? Getting like quantities of crud off of your hands. So if you have sort of a buildup of something gross that wound up on your hands for some reason or another, all those waterless hand sanitizers and things like that are really just kind of not the best substitute, because they're not going to decontaminate your hands that way. Soap and water, please and thank you. And the one thing I think we drove home yesterday when we were ventilating those mannequins for one breath every 6 seconds, the 20 seconds that you're supposed to be washing your hands for seems like a really long time when you actually do it appropriately. Because I was somebody who washed my hands after every patient contact. And what I came to realize was the first time I actually did stand in front of a sink and hum happy birthday twice, 20 seconds is forever. Always wear gloves. Always, always, always wear gloves. I will tell you that this is one of those do as I say, not as I do things, because I was in the terrible habit of, unless I knew I was going to be involved in something disgusting, I probably didn't have gloves on. And that's more because I'm a jerk than anything else. If you're touching a patient or working on like extricating a patient, anytime your skin's going to come in contact with something that doesn't belong to you, put your gloves on. When you're cleaning the back of the ambulance, be very, very careful to wear some of the more heavy duty, like cleaning type gloves, because there's a lot of stuff that you can get sort of snagged on or cut by in the back of the truck. And that's just another route for infection. And always change your gloves between patients, and do both yourselves and your partner a favor. And if you're working on a patient, you have a pair of gloves on and you need something out of your first in bag, you need a bandage, you need a blood pressure cuff, you need anything out of that bag, swap your gloves out. Don't touch your things that aren't dirty with gloves that are dirty. So take your gloves off, get what you need out of the bag, hand it to your partner, put another pair of gloves on, and go back to work. We will go over the removal of gloves because there is a very sort of choreographed way to take your gloves off so that you're not actually touching yourself with gross gloves. That's, really sort of, it's not worth wearing gloves if you're going to go ahead and rub dirty gloves all over yourself. So we'll talk about that today when you guys get into class. Eye protection and face shields. Now, I have had a workplace exposure. I was working on a patient who had had a seizure. During his seizure, he had bit the inside of his mouth. He started coming back around and after his seizure, but he was still altered. And I had put an oxygen mask on his face and was giving him some oxygen. And he pushed the oxygen mask off his face and went like he was blowing raspberries, but instead he was blowing blood all over my face. I had done something that I knew was stupid, but I was just in response mode. It was caught off guard when I was at work, and it wasn't really, it was a pretty much a cacophony of things that went terribly wrong. And I wound up having to follow up with occupational health because I had an unprotected exposure. I wound up on 28 days of antiviral medication because I had an unprotected exposure, and it wasn't a rocking good time. And to be honest with you, if I had just put on some goggles and put on my face shield, I never would have had that problem because wet and sticky and not mine would have been on the goggles or the face shield, not all over my face. So protect yourselves, really, really protect yourselves. If you've never had the opportunity to take an antiviral medicine, it is not fun. So gloves and eye shield, generally that's going to protect us from most things. Now in times of COVID, you'll catch us wearing N95 masks and regular surgical masks and things like that a lot more often, just because, we're hoping everybody keeps their germs to themselves and this COVID nonsense goes away sooner rather than later. If under normal circumstances, you are, responding to a patient who has a significant injury and maybe they are just uncontrollably spraying blood all over the place, or, just uncontrollably vomiting, you want to keep that off of your clothing because your clothing touch your person. On top of all that, you are then soiled when you're either getting into the passenger, the patient care compartment, or the driving compartment of the ambulance. So it really just adds to the possible routes of transmission. So the more extensive sort of what it is that you're going to be dealing with is the more personal protective equipment you're going to need. Masks are the order of the day now. So we are wearing a mask all the time. If we're just expecting on normal days, just some fluid splatter, like with suctioning an airway or something like that, that we'll work on a little bit later, we would probably just wear a standard surgical mask or a mask and eye shield so that we make sure our eyes are protected as well. But there are certain things that are airborne. There are certain times where an N95 mask is the order of the day. An N95 mask is got a HEPA filter inside of it that will filter out just about everything. It catches particles down to 95 microns in size, which is itty bitty teeny weeny. So if you are being exposed to something airborne like TB or COVID, or you think the patient may have something like that, go ahead and put on this mask. It's going to be fitted to you in orientation. We test these at orientation to make sure that you have a good mask seal and it prevents any airborne particulate from entering through the size of the mask. Always protect yourself one level higher, really, than you think that you may need to. There's no shame in keeping yourself safe. There are some times where you will be around needles. EpiPen auto injectors, they're supposed to have a safety catch on them so that the needle gets covered the minute that it goes back into the housing of the EpiPen. Sometimes that needle will get bent and the needle itself doesn't always get covered back up like it's supposed to. Sometimes we actually will give IM injections to our patients with an actual needle and syringe. We don't recap needles. Never ever recap a needle. If it doesn't have an automatic safety to it, we make sure we throw it right into the sharps bin, right into the biohazard container. You don't put it down, you don't drop it on the floor. You take that needle, as soon as it leaves that patient, it goes in the biohazard bin. Whether it's an EpiPen auto injector or whether it's an actual needle and syringe that you just use to give an injection, don't get complacent with these things because complacency gets people stuck. Let's see, we already talked about that. What our plan is you'd call the designated infection control officer and she would tell you what to do or tell you what your options are. Because really, at the end of the day, some exposures are of low risk, some exposures are of a bit higher of a risk, but you're the person who makes that decision. If it is a significant enough exposure to you that you want follow-up and you want to be seen and you want to have blood drawn and you want the whole shebang, you follow up with occupational health. Because really, once you've decided that you don't want to be followed and you don't want to go through all the steps of making sure you were okay to begin with, it's too late. You have to have blood drawn almost right away to make sure that you didn't have something to begin with. You have to have follow-up and medication most of the time within 24 to 72 hours for them to be effective. So if you have an exposure and you think it's a significant exposure, then it's a significant exposure. No matter what anybody else tells you, no matter what they tell you the odds are, if you're worried about it, be worried about it.
Tommy,
Yes.
did when you got the blood spattered on you, did you make that decision to go, or did someone tell you to go? And
No, I made the decision, even knowing that it was a low risk of transmission. I knew there was still a possibility, and I also knew that the patient was hepatitis B and C positive.
Oh, okay.
Hepatitis is way scarier than HIV. HIV is almost immediately deactivated by oxygen when it's outside of the body.
Mhm.
if there was just a few drops of hepatitis B infected blood in a swimming pool, they would have to drain the swimming pool to make sure that nobody got hepatitis.
Oh, really? Oh.
Yeah, hepatitis is way, way scarier.
How'd you
So,
know that right off the bat, though, that they had that? They just said it?
no, it was just where I worked. I had access to all that information.
Oh, okay. And then you were out for 28 days because of the
No, I went to work.
antibiotic?
No, I went to work. So if you look at some of the, they put you on a cocktail of, they call it a cocktail, right? They put you on antiviral medicines to make sure that since I wasn't HIV positive to begin with, I didn't become HIV positive. They drew blood to make sure that my hepatitis B vaccine had converted and I was still immune to hepatitis B. They made sure that I didn't already have hepatitis C and then followed that as well. The medicines that they give you are like side effect hell.
Oh,
And to be honest, and take this with a grain of salt because I've done it and I would probably do it again, but it was almost unpleasant enough for me to be like, you know what, I don't care if I get sick. I would do it again just because I don't, that's a lifelong decision. But
right.
it was not fun, happy times for the next 28 days. But no, I did go to work.
Hmm.
Lots of stuff should be part of our daily routine. Get in the habit of checking your equipment, get in the habit of checking your truck, get in the habit of cleaning your truck. Make sure your truck is stocked, but don't overlook the fact that, back of the ambulance is dirty. So make sure that you have gloves available. Make sure you have cleaning product available. Make sure you have the things that you need so that you can not spread other pathogens, not contaminate yourself over and over and over again. Because sooner rather than later, if you go poking the hive of contamination for long enough, eventually something's going to happen. You'll cut yourself and wind up with like a skin infection, so a staph or a MRSA or something like that. And if we really tidied up our work office a little bit as much as we did our home, we could probably avoid some of that stuff. So this is pretty simple, right? If you have immunity, so like I mentioned with checking to make sure that my hepatitis B vaccine was up to snuff. I was immune to hepatitis B, so I wasn't going to catch that. If my vaccine hadn't converted, because sometimes it doesn't, or if it had worn out and it had been too long, I would have needed to be vaccinated again to build up my immunity. Some of the things we can do to help out our immune system itself is maintain our personal health. Get the vaccines that our doctor advises us to, and really just try to make sure you make as many healthy decisions as you can. Now, I'm not saying, start CrossFit and become vegan, but if you take care of your body will take care of you. So what to do if you have an exposure? Turn the patient care over to another EMS provider if you can. Clean the exposed area. So let's say, for argument's sake, just for a moment, that it is a needle stick. The first thing you're going to try and do is squeeze the area and wash it off. Now, whether or not this works or has any effect, I have absolutely no idea, but you want to try and expel blood. We want to try and get some of that out. Then wash your hands for an extended period of time with soap and warm water. And then activate the infection control plan. Call dispatch, call the SOOP, call the DICO, the designated infection control officer, and report this exposure and the time of the exposure and the route of the exposure and all of that stuff to those people. because you're trying to start a paper trail to make sure that, you get the protection that you need. If the exposure happens to be in your eyes, you're going to rinse your eyes for at least 20 minutes. In the hospitals, they have those eye wash stations. In, some other facilities, they might have those as well. If that's not available, head under the faucet and you rinse and rinse and rinse and rinse and rinse for 20 minutes. Not a super fantastic sensation. It feels like being drowned, but it is absolutely necessary. You need to wash as much of that contaminant out as you can, because your eyes are really just sort of a mucous membrane. The route of getting that contaminant into your body through your eyes is actually really pretty quick. So this is something I think we take for granted, and we shouldn't. Scene safety begins the minute you are dispatched. Start thinking about making that scene as safe for you and your partner as you can. If you're being dispatched to an accident on the highway, make sure your vests are available. If you are responding somewhere, you should always be wearing your seatbelt in the ambulance, whether it's in an emergency mode or whether it's just driving down the street. When you get out of the truck, put on your personal protective equipment. That way you can't forget, or you can't get caught sleeping like I was and wind up involved in something without properly protecting myself. We want to start looking around for any scene hazards. If you see smoke as you're approaching, something's probably on fire. If you see down power lines or broken poles near the accident or whatever it is that you're responding to, take note of that, because just because a wire is down doesn't mean that it is not still charged. Hazardous materials is one of those things that we'll talk about in Chapter 9, Part 1, I believe, and most of this stuff, really, identifying your scene hazards and trying to make sure that you remain as safe as possible on the scene, is really what we're going to talk about in that scene size up. Dress appropriately for work. We don't carry turnout gear, but if you know it's raining, wear your rain gear. If you're going to be around things that require you to wear eye and ear protection, you will be provided that. Your skin protection is going to be your gloves. If you say are at an accident scene and they're cutting somebody out of a car and they need somebody to go into that car, they will provide you with the turnout coat or bunker pants or something like that to make sure that you're not getting just cut to shreds by glass and jagged metal and things like that. But really, it's just making sure that you are doing the things that you need to do to take care of you. Now, when we're caring for a patient, it's not just we walk in and start doing. There's some interpersonal communication. There is some sort of relationship development here between you and your patient. Walk in, let them know who you are. Explain what you're doing as you're doing it. It's going to do more to put them at ease. The fear of the unknown when EMTs or paramedics or whoever start working them up in the field really kind of is unnerving for patients. And if we can sort of set our patient at ease and the family hears us explaining, it gives us a bit of an air of confidence, and it shows that, yes, there is stuff going on. Yes, I am evaluating this patient for medical complaint X, Y, or Z, or traumatic injury A, B, or C. But if you are really just sort of methodically working your way through and making sure your patient remains informed, that informed consent, right? You will just really sort of set the tone for making sure, no matter how serious this illness or injury may be, everybody's going to have a good experience. Everybody, when we get our suggestion box letters at some point, they're going to say, ambulance crew was great. They explained everything that was going on. They made sure to take good care of mom, dad, sister, brother, whoever. And, everybody really felt at ease regardless of what was going on. Most of the time, these are some pretty straightforward things, how our patient responds to being critically ill or injured. First of all, well, let's call it what it is. They're going to be anxious. Of course, they're going to be anxious. Most of the time, the patients know better than us just how messed up they are. Their body tells them that they are in some bad shape. Pain and fear, absolutely. Probably the more pain, the more afraid. Some people are just going to be mad, especially if they know that they're dying and haven't really had a chance to make sort of their peace with that. Anger and depression are really something that is sort of status quo. How do we combat some of this? Well, we're going to avoid sad and grim comments, of course. Orient the patient. These really are, a lot of these things are just speak to your patient. If your patient doesn't want to talk about what's going on with them, you can get through the wealth of your patient assessment and then start talking about football or the Red Sox or anything that really might sort of get them out of the funk a little bit and involve them more in their care. I have never in my life lied to a patient, and I'm too old to start doing those things now. If your patient asks you a question and you think the answer is negative, you may have to deliver negative news, but don't crush their hopes. Don't make them quit. Tell them, you're in rough shape, but I'm going to do everything I can to make sure that you don't get any worse, and we're going to get you to the best care we can as quickly as possible. I didn't lie to them. I said, hey, you know what? You're pretty banged up, but we're here now. And you know what? Nobody dies in my ambulance on Thursdays. So let's get you to the emergency room. Let's get you all patched up and let's get you on with your life. If you have a child that you're going to be transporting, try and get an adult to come with you, somebody who knows the children. Yes, we're going to do all the same assessment type things. We're going to do mostly the same interventions as well, but see if a family member or someone who can calm the child or who the child feels comfortable with will come with, because we're strangers. And that's going to add another little level of anxiety and fear and worry and wonder when mom and dad hand them over to this stranger who's now driving away with them. Death of a child, that is something no parent should ever have to endure, but it does happen with things like SIDS and, just random everyday accident and occurrence. I mean, we learned about pediatric cardiac arrest yesterday. Help the family as much as you can. You really have multiple patients in a situation like this. Yes, you are responsible for the medical care of your actual patient, but somebody needs to look out for the well-being of the family on scene. And, well, there's two of us, or there's firefighters, or there's police officers, or there's other responding ambulance units. And somebody should take the time to speak and work with this family to make sure that they're not alone, to make sure that they are not just standing over in the corner watching horrified as we do unspeakable things to their child who's in cardiac arrest. Death obviously can occur quite suddenly, or it can occur after a prolonged illness. Sudden death is oftentimes way more traumatic for the family, the patient, and really everyone involved. Death after a prolonged illness sometimes can really be looked at as a positive thing. Generally, there are these 5 stages of grieving over on the other side here. Most patients who have a prolonged or terminal illness and know that they are reaching the end of the road, they do work their way through all of these steps, not necessarily in this order, but they do sort of get there. Denial, who's dying? Not me. I'm not sick. I'm going to live forever. Then they go through the anger and hostility stage where they are just mad at everyone about everything. This is not personal. This is not, the time to be like, oh yeah, well, this is just them's the breaks. They're gonna be mad. They're gonna be ornery, and really, that's just the way that it goes. The next one, really, to me, is sort of the saddest of all of these things, the bargaining stage. This is someone who is beginning to sort of come to grips with the fact that they are going to pass away. But they say, all right, well, I'll be okay if, I just get to see my grandkids one more time, or I never got to go to opening day, or if I could just make it to my son's wedding. And they start to almost catalog all the things that they're going to miss and they're not going to get to see. And the bargaining stage is not real easy to be part of. Once they get to depression, yeah, of course they're going to be sad. Nobody wants to go, but nobody makes it out alive. The depression stage, they normally get through pretty quick. This is, some pretty profound sadness, thinking about all the good times, thinking about all that they're going to miss, and thinking about all the ones they're going to leave behind. But sooner rather than later, people generally do get to the acceptance stage as they're working their way through these stages of grieving, whether it's the patient themselves, whether it's their family, whether it's friends. And you realize that, with these prolonged and terminal diagnoses and, the actual process of dying and the actual process of grieving is no real way to live. And, you'll have people that all of a sudden turn that corner into acceptance and say, I've lived a good life. I'm going to miss my people, but, it's time. And generally, we get to the acceptance stage, the whole it's time generally approaches pretty quickly.
I have a quick question.
Yeah.
Have you ever gotten emotional, like in front of the patient and or family, like on the job? Like uncontrollably emotional, like where it's just been like you see something like grieving and the state, like someone like in the bargaining stage, you said it was difficult to see. Have you ever gotten emotional where you showed it?
Showing emotion, sure, but like unable to control it, no. Um, I learned early on that, and remember I said I'm not the picture of healthy coping mechanisms, right? I learned early on that some things just get put in a box and shoved way down because I have a job to do.
Right.
Yes, have I shown emotion with patients and with their families, and have I held old ladies' hands on the way to the emergency room and felt just awful while doing it? Yeah, I have. Have I gotten in fights in nursing stations with, people who I thought were treating the patient kind of crummy? Yep, I have. And at the end of the day, I have to make the clinical decisions. I have to look at this as I have a job to do and I'm going to accomplish that job. And you know what? I might go out into the parking lot afterwards and throw my clipboard across the parking lot. And then I mutter and sputter and curse the whole way to go pick it up because I know I got to go pick it up. Um, on scene, you got to work to kind of keep it together.
Yep.
And this is how you do it. You know what? Ask how you can help. Be part of the process. And I know that's uncomfortable. I really do. I really, really do. But medical care at this point, like, right, is especially someone who knows, that they're going to pass away. I mean, I was my father's hospice care provider. I knew that there was absolutely nothing I was going to do to be able to get him out of this. But ask what you can do to help. Ask what you can do to make them more comfortable. Give yourself something tangible to do to try and make this process less sucky for everybody. And you actually can control that emotion. You can start to feel better. Allow these people time to grieve and let them know that you're there to make this whole process better. Be honest. I'll tell you, I was dropping someone off to a hospice care place once, and the patient was great. He was still lucid, wasn't in a ton of pain. I really enjoyed chatting with him because that's all I knew. That's what I was there to do. And we dropped him off. We put him in bed, and I'll never forget the words that left my mouth. The guy, I don't remember his name at this point, but it was like, I said, all right, well, I'll see you later. Have a good one. And I stopped dead in my tracks because the patient went, no, you won't. And I went, I don't even believe that those words just left my mouth. Like, I was dumbfounded by how stupid I had just been. But I'm a person. I make people mistakes. It happens. Did I just reinforce reality? No, not really. Was I being honest with the patient? No, not really, but not on purpose. Luckily for me, I got out of that one without being headless, because there are times where you're in that emotionally charged situation and everybody would want to yell at you for that. Just be the best part of it that you can be. And it really you'll watch it take the edge off a little bit because they know that you're there to help. So anything that you do that's helpful is really going to benefit all parties involved. So nobody wants to hear this top stuff, right? Give it time. It'll get better. Don't question God's will. You have to get on with your life. Just keep on going. This next one, holy buckets. You can always have another child. You're not the only one who suffers. The living must go on. I know how you feel. Don't get carried away and say things that are absolutely ridiculous. Use a whole lot more like kid gloves in situations like this, and validate people's feelings. You know what? I'm sorry for your loss is sometimes the only words that need to leave your mouth. They really can be every bit as helpful as anything else you could say. You know what? I really am sorry. And actually be sorry. It's okay for people to be mad. It's absolutely okay for people to be mad. Some people aren't going to want to accept this, especially when it's fresh in their mind and it's brand new. But you know what? This next one, tell me how you feel. You know what? Let me help you. Tell me what's going on. If you want to cry, it's okay. Absolutely. Reinforce the fact that somebody really cared for the person who just passed away or is passing away. There's no harm in like I mentioned earlier, showing a little chink in the armor and really letting somebody know that, you know what, there is emotion involved in this and you are sorry and you want to be there to help. But also let them know that their feelings, whether it's sad, whether it's angry, whether it's just depressed or sobbing uncontrollably, all of those things are okay. You just can't go to pieces with them. Is it okay to cry with patients and their family? Absolutely. Absolutely it is. But you still have to be able to accomplish the task at hand. So there are 3 stages to the stress reaction. We have the alarm response, the reaction and resistance, and recovery. Alarm is when you're first exposed to that stressful situation and your body's going to do all sorts of things. We talked about the autonomic and sympathetic nervous systems yesterday, and our reaction, everyone's reaction to a stressful situation is the same. Your body dumps a whole lot of adrenaline, a whole lot of epinephrine is coursing through your veins, and it does this. Your respirations and heart rate are going to increase. You start getting that cool, clammy feeling to your skin a little bit because now your vasculature is constricted way down. Your pupils dilate to let in more light and allow more visual acuity so that you can make better decisions. Your muscles will tense up because they're getting ready to fight that bear or run away from it. Your blood glucose will actually go up because your body's going to need that to create energy. So your body will release any sugar stores that it has available to it, so that you have an absolute plethora of oxygen, blood, and sugar running around inside your person to make sure that you can do all of the things that you need to do. You start to sweat a little bit. And if you're involved in a situation where your body had to dump all this adrenaline and you're getting ready to fight or run away from a bear, do you think your body really cares about digesting breakfast?
No.
Absolutely not. So it actually will decrease blood flow to your gastrointestinal tract. That's why a lot of times when you have that adrenaline response, right, you'll have like rumble guts and a bit of an upset stomach. That is physiological. There is nothing you can do to stop that. We put ourselves in all of these dangerous situations, physical and psychological demands, dead or critically ill or injured patients, overpowering sights, smells, and sounds, name it, we do it all. And then you add to the fact that our job is a bit unpredictable by nature. You can go from working just a monotonous, mundane, average every day for the first 12 hours of your shift, and then everything goes to hell in a hurry over the next 2, and you wind up working, a cardiac arrest, a bus crash, a possible terrorist event, you name it, and it can be there because that's what we're on the hook for. So our acute stress, that happens right then in the moment. Delayed stress will happen after the event. So we've actually built up a bit of a resistance, and our body still produces that epinephrine, but we don't feel stressed in the minute. And those delayed stress reactions can kind of tend to pile up. And when they do, we wind up with cumulative stress reactions. And that cumulative stress is being exposed to stress without relief for a prolonged or excessive period of time. And your body really never gets a chance to come back. Those are really like the absolute marching path to things like post-traumatic stress disorder. It can be avoided, and it should be avoided. Yes, we're involved in stressful situations, but if we involve ourselves in a way to sort of fix the stress that's involved and put ourselves in a better headspace with things like critical incident stress management or critical incident stress debriefings, where the people involved in the incident will actually come together and talk about the incident. And nobody's there to Monday morning quarterback. Nobody's there to say, well, if you had done this, this would have happened and everything would have been better. That's not the way these things go. It's not a witch hunt. It is actually meant to promote your mental health and well-being. It really diffuses the situation a little bit and takes the edge off. We have people here that are certified to actually help with these things. So if, work life or home life are really at some point or another giving you a whole bunch of lemons, reach out and touch somebody. You can send me an email. You can call my work phone. I will absolutely be in touch. There's other people in this office that are probably even hands down better at that than I am. So know who you can lean on and lean on those people. So this is in the book, table 2-8, the warning signs of stress. Now, let's take a look at some of these things. And I want to ask you guys a question. So I'll give you a minute or two to look at this, chart up on the screen. And then I want to ask you a question. All right, everybody get a chance to look through that stuff?
Yeah.
All right, so here's my question. If your patient was reporting any of these things to you, would you be concerned about the mental well-being of your patient?
Yes.
All right.
Yeah.
If your partner was telling you any of these things, would you be concerned about the mental well-being of your partner?
Yes.
Okay. So why in God's good name do we find it so damn easy to ignore these things when we're doing them to ourselves?
Because you don't want to bother anybody.
Yeah,
Like
you don't want
with
to bother anybody. It's
with your
difficult to
problems.
admit.
You don't want to appear weak.
Yeah,
Yeah,
right.
weak.
All of that is garbage. If it's concerning when someone else is doing it to themselves, it should be concerning to you too, and you should reach out to somebody. I will tell you from experience, the admitting that you have a problem and admitting that you need help to deal with that problem are two of the bravest things you could ever do. So you look at this list and you see all of those things and you go look and you go, holy crap, if my patient was telling me that, I would think that there was something wrong with them. Holy crap, if my partner was telling me something like that, I would think that there was something wrong with them. And then we look at that list and we go, if any of those things would happen to me, I'd get over it. I'm not going to tell anybody about this. I'm not going to bother anybody with this. This is my problem. Baloney. Make it somebody else's problem. Talk to your friends, talk to your family, talk to your coworkers. Drop by the office and talk to me. Use some of that critical incident stress debriefing. Use some of the resources that are available to you, because this is no way to trudge through life and then sit back and go, I just didn't want to bother anybody with this. Because sooner rather than later, all of these things catch up to you and you wind up worse off than you needed to be. When you're in a stressful situation, we want to use extreme care with our words and actions. Just be careful. Our job is absolutely to bring a sense of order to that situation. So, like I said, be the duck. Allow patients to be afraid and express their concerns, but also do what you can to sort of calm those waters and make them less afraid. Even if you are afraid for them, just get you both through it. Going to a shambles is not gonna help anybody, and it's gonna make you feel worse. So really just be there, even if all you have to offer is a hand to hold. That's fine. There are times where we run out of stuff to do, and maybe we've already done it all, and now we're just transporting, and the patient is still scared to death. That's okay. Lord knows there's enough of this stuff going on lately. Be wary of violent situations. Stage where you're told to stage and move when you're told to move. When these kind of things are going on, freelancing is not the order of the day. Absolutely just wait for further advisement. Wait until the area has been declared safe so that you don't wind up getting turned into another patient. Behavioral emergencies are just that. It's when somebody's behavior has gotten to the point where it is no longer in line with what is the social norm. It doesn't have to actually be loudly violent or obviously physically violent to be a possible violent scene. It doesn't even have to be a real for life mental disorder. Things like hypoglycemia, head trauma, hypoxia, those are all things that can make a patient altered and act outside of what is their behavioral norm. So treat these things cautiously and, do what you need to do to provide for scene safety. All right, folks, we are back. Our chat now is going to be on patient assessment, part 1, the scene size up. So scene size up is basically how not to turn yourself into a casualty 101. I think now you've probably gotten the hint that scene safety should be your paramount on every single call. Calls only become completely and totally safe when we are cleared from them. We have dropped off our patient. We are no longer responsible to patient care, and we are sitting tucked safely back away in our ambulance. So let's take a look at this right here. And can anybody tell me what I think might be wrong with this picture? Anybody? Nobody?
I don't know where the patient would be that she would be checking out the area.
So even bigger than that, you're close. But take a look at that probably 500 or 1,000 gallon tank that she is using those binoculars to scope out. Now, generally tanks like that outside of buildings have something flammable and or explodable inside of them. And they are at most 50 yards away from that tank.
Yeah, they're a little close.
Yeah. So scene size up begins before we ever even get out of our ambulance. If you're thinking enough about that tank being significant and needing to get a closer look at the placards that are on that to figure out what are in that, they are far and away way too close without enough things between them and whatever it is that may explode. I would be at the corner of that building at best and looking with my binoculars from a lot further away than that. If you're responding to something, a tanker accident or, a chemical factory or something like that, because there are places around here that have all of those things in them, chemicals, petroleum products, things that can go boom. Be far away. There's no reason to be on top of that. Start your scene size up as you approach, so you don't wind up driving up on top of something that, might be leaking something hazardous or is a danger and a hazard of either combusting or exploding. So our scene size up, here's our steps. We're going to check for scene safety. We're going to take our standard precautions or our body substance isolation or our PPE, whatever you want to use. Use those precautions all the time. As we're getting closer to the scene and starting to begin our evaluation a little bit, we want to start thinking about what was the mechanism of injury or what is the nature of this patient's illness. Now, obviously, mechanism of injury is what caused this patient to be injured. Car crash, fall from a roof, simple slip and fall. That's your mechanism of injury. Nature of patient's illness sometimes can be a little bit more difficult to sort of figure out at a distance, because most of the time we figure out our nature of our patient's illness from some dispatch information, because they're going to tell us to go to 123 Main Street for the chest pain or the respiratory or the unknown medical. But some of the times that doesn't really give us a whole bunch of information. You can't really figure anything out from go to 123 Main Street for the unknown medical, or go to 123 Main Street for the chest pain. And the whole time you're on your way there, you're thinking, all right, cardiac, medical, chest pain, respiratory, chest pain. And you get there and your patient has been hitting the chest with a golf club, like different strokes for different things. these are things to keep in the back of your mind. Mechanism of injury. Okay, it's a fall off a roof from a ladder. All right, well, my patient's likely to have, bilateral lower extremity injuries, some possible spinal injuries, some this, some that, a little from column A, a little from column B. And our nature of a patient's illness is, all right, I got dispatched for a chest pain. If this is a medical, I know, all right, the thoracic cavity. We have all the muscles and structures responsible for breathing. We have the heart. We have all the great vessels. So you start putting things together a little bit as you get there to make sure that you have kind of all your ducks in a row and you're figuring out, what am I going to do for this person when I get there, and making sure you can dot all your I's and cross all your T's. Determining the number of patients is really important to get a handle on early in your encounter with the call you've been dispatched on. Now, I saw yesterday on, I think it was on the news, there was a 2-car motor vehicle collision in, I think it was Texas. It was a tractor trailer versus an SUV. There were 25 people tucked inside that SUV. 13 of them were killed. 25 people. Would you ever pull up to a 2-car MVC and expect 26 people to be your patients?
In the SUV? Like, how big was the SUV?
It was like a Suburban or something like that. I mean, it was big, but it wasn't 25 people big.
Wow.
They were packed in there pretty good.
Yeah, they were probably stacked like lumber. As soon as you pull up on something like that and you see that, all right, there's 2-car MVC, that seems pretty innocuous. That should be easy peasy, no problem. But as soon as you're pulling up and you haven't even stepped out of the ambulance yet, and you see damn near 30 people milling about, do we have enough resources to handle that with just you and your partner?
Oh, God, no.
Yeah, so we need to decide whether we need any additional resources. Now, our decision about additional resources isn't always just patient specific. You could need the electric company because there's been a break in a power line and there's live wires down on the road. You could need the gas company because, now we have an odor of natural gas and we're thinking, holy smokes, this whole area could go. You could need additional police cars or additional fire personnel. So the time to decide when you need additional resources is early. You're better off asking early for police, fire, other additional EMS resources, because sometimes we need more hands. Sometimes we need more special capabilities like the electric company, the gas company, and this is all part of sizing up the scene. A lot of this is done ahead of time. Some of it is done as we're making patient contact and figuring out sort of what it is that's going on. It's fluid. You could get on scene and, all right, we have a 1-person call in, 911 call for a patient's husband, and they send just 1 ambulance, maybe a cruiser, maybe an engine, and the next thing you know, you walk in the house and the patient's 600 pounds. All right, well, we don't have the equipment to transport someone who's 600 pounds really in a normal ambulance. We don't have the people on hand necessary to move someone who is 600 pounds. So as soon as you figure that out, you hop on the radio, hop on your cell phone and say, hey, by the way, this patient is 600 pounds and we're going to need some help. And then your help comes. So this is something to keep in mind at all times. The only thing predictable about emergencies is they are often unpredictable and can pose many dangers. And it's oftentimes things that you don't even think about. Constantly reevaluate your scene. When a dispatcher, an emergency medical dispatcher, is on the phone with somebody, one of the last directions they give is, if there's any pets in the house, please secure them. Because even the friendliest of dogs, when you go in and start messing with their owner, will bite you, period. I mean, my dog runs away from people. He's not aggressive one bit. But what I can tell you is, if you were in my house trying to work on my wife, My dog would not let you within a country mile of her. Not going to happen. So think of all the additional things that go into all this and just know that the environment is fluid. And if you decide at any point that scene safety has been compromised, it is time to get out of there. Cut bait and go fish somewhere else.
Now, if a scene becomes unsafe, would you try, if you're in the middle of doing something, would you just try to grab the patient and beat it or just bail?
So it depends. If at all possible, I would try to bring the patient with me, if that's even a legitimate possibility. If it's not, bail. Dump the gear, dump whatever you have to, and just get out of there. There are times where just dumping everything and evacing is way, way better and way more beneficial to you than anything else you could come up with. You're going to go back, right? I mean, it's just the way of the world. Sooner rather than later, the cavalry shows up and we will be able to re-enter that scene. You just don't need to turn yourself into an addition to the problem. So what do you think are some threats to emergency providers on scene? Let's answer this question.
The flammable tanker.
Flammable tanker, no kidding, right? But I just mean on really any scene in general. It doesn't even necessarily have to be with this picture. What are some things that could present a hazard to you?
With an MVC, you got oncoming traffic, you got hazardous material, and like you said, when a lot of times you guys respond, pets on scene, definitely. Or like with an assault, you have violent people. Just to name a few.
Yeah, no, you're absolutely right. You are. And some of the ones that generally oftentimes don't get thought of is just like you were saying, the oncoming traffic. The fact that, we are sort of out there playing Frogger, trying not to get run over sometimes. When you are approaching a scene, we're going to use all of our senses, right? We want to look, listen, smell, see, whatever you can do to get yourself as much information as humanly possible is what we're looking to do. So look for other emergency units approaching. Generally, we're not always coming from the same direction as necessarily the fire engine or the cruiser or other responding EMS units could be. And you'll see it a lot of times. And when you guys go through orientation for, when we've completed the program, we do a driving class. And in that driving class, they show, like, I think it's an ambulance and a fire engine. Neither one of them cleared the intersection appropriately, and they just total each other. So pay attention to what's going on around you is really sort of the word of the day. These look for collision-related power outages. Yeah, it's not always just right in the area of the accident that we'll start to see some possible power problems. If somebody hits a pole, it can affect entire blocks depending on what was connected to that pole. So as you're looking around and as you're approaching, if all the houses in this neighborhood are in complete and total pitch darkness, that's weird. You might need the power company. Observing traffic flow for sure. Generally speaking, the police do a really good job at sort of keeping traffic off of us, and fire engines are huge. So they will use police vehicles, fire engines, ladder trucks, whatever it has to block traffic somewhat and give us a safe working environment. But as we've seen, sometimes the lights will attract people's attention. Sometimes people just aren't paying attention. And the next thing you know, those apparatus that are being used to block you are now being run into and being pushed on top of you. So again, keep your head on a swivel. Always, always pay attention.
I have a quick question.
Sure.
If say like the police officers or firefighters aren't there yet and the scene is unsafe, but I know that this has to do with like the scene size up and everything. Don't start until the scene is safe, but you see that somebody is like you know that it's it won't be obviously you make the decision where the it's not that much traffic, people realize something happened, so you go in anyways. Like, is that, and like, does your partner kind of help with the traffic, or do you just keep waiting? Like, or is it a judgment call?
It's a judgment call. It's definitely a group decision. If you're gonna get, there are times where you'll be the first person on scene and you'll be the first vehicle on scene. Park your vehicle so that it is providing you a safe workflow. Use the ambulance. Close the back doors because you don't want somebody going by to rip a door off and throw it on top of you. So park the ambulance right in the middle of traffic, block as much as you need to make sure that you don't get smushed. Close the doors and point the wheels away from where you're going to be standing so that they have to not only hit the ambulance, but almost completely spin it around before it winds up on top of you.
So say, for example, like what if I'm on the right side of the vehicle, or what side, how should I put the wheels? I'm just trying to picture it.
You wouldn't be on the side of the vehicle, you'd be out past the nose of the vehicle at that point.
Yeah.
So if you're going to be working in front of the vehicle, you pull it so that the truck itself isn't pointed directly at you. It's pointed either off to the left or right, depending on where you're going to be standing and working. If you're going to be if you're going to be working off to the left, you point the wheels to the right. If you're going to be working off to the right a little, point the wheels across traffic to the left.
Okay.
So now we are within sight of whatever it is that we're responding to. We want to start looking for clues of any escaped hazardous materials. If it's a collision, we want to look for people in the roadway. Cars these days are built so that they will look totally and completely demolished. You'll see the vehicle and go, oh my Lord, how did anybody even survive that? And people will be out walking about posting pictures of the car accident on Facebook. It's remarkable. So look for people wandering around. Still, we're looking for any smoke or any broken utility poles and downed wires. If we have other responding people on scene, we want to go ahead and follow whatever it is that they're directing us to do. Most of the time, they will put us in a good spot so that we can both work on our patient and get out of there once we have worked our patient up, extricated them, and gotten in the truck. They're not going to put us somewhere where we're going to get boxed in or, be in the way. So if police are there and they're directing traffic and they point to you a spot to park in that spot. It's generally done for a pretty good reason, and they're already on scene figuring out the wheres and what fors and best places to put the people. If it's a pretty large sized incident, follow instructions of whoever's incident command. Now, I know we've talked briefly a little bit about, if it's a medical call, then we're the people responsible for it. If it's a trauma and our patient's going to the emergency room, they are our patient first. That doesn't mean that, if a fire captain is saying, hey, we need you to park over here because we have to run a line because we need to put out that engine compartment. There's a bit of a give and take, and there's a lot of moving. It's like playing human chess. Yes, the patient belongs to you, but that doesn't always mean that the scene does, because there are other hazards and other things sort of going on. I think we've talked lengthy enough about our personal protective equipment. Make sure you have everything that you're going to need with you. Load up the stretcher. Put as much stuff in your pockets and on your person as you have to. I always hated if I forgot something in the truck. So normally I looked like a pack mule when I was going into an emergency call, because emergencies are all different and you never know what you're really walking your way into. So I would carry everything that I could to avoid having to go back outside. If there is a hazard, we're going to establish a danger zone. We want to take a look at what the hazard is if we can. There are binoculars in the truck. There are NIOSH guides that will tell us what those placards on different tankers mean. There are material safety data sheets available anywhere that they store chemicals that will tell you sort of what it is, how dangerous it is, and what steps do you need to make, other than big ones fast in a different direction. Different hazards will require a different sized danger zone, but if you can't identify what it is, give it a pretty wide berth. If given an option, we always want to try and park uphill and upwind from any escaped hazardous materials. Uphill so that, things aren't running down the street into where you're at. So we want to be at the top of the hill instead of the bottom. And upwind meaning we want that wind at our back so that the wind direction is not blowing whatever that hazardous material is over on top of us. The wind will be blowing everything away from us. So uphill and upwind. We're constantly evaluating for violence. There are some things on this list that, are obvious when you show up and you hear fighting or loud voices, you see visible weapons or weapons in use. If you have been dispatched to a shooting, to a stabbing, to an assault, if something violent has happened here, it's quite likely that something violent will happen again. So get to know your service area a little bit and know where some of the trouble spots are, and know that, every Friday and Saturday night, we wind up at this same house because somebody got bombed and got into a fight. Or every time we go to this neighborhood, it's because somebody's been beat up or somebody's been shot or somebody's been stabbed. At those kind of places, when you become familiar with those addresses, it's probably a good idea to make sure that you are paying very, very close attention to the things that are going on around you. Signs of alcohol or drug use, absolutely. People don't generally make the best of decisions when they are intoxicated in one way or another, whether it's drugs or alcohol or both. So pay attention. Unusual silence, this is that creepy one. You expect chaos at an emergency scene, right? You expect things to be sort of highly charged, and then you show up and it's like those old Western movies where there's tumbleweeds and everybody just turns and stares at you when you walk in the door. If that sixth sense that you have, that little feeling you get in sort of the pit of your stomach is saying, hey, there's something wrong here. Guess what? There's something wrong here. That little sixth sense, that little pit in your stomach, that little voice that tells you, this is not good, is a built-in defense mechanism. It's built to pick up on things that maybe you don't really see right off the bat. And get out. There's something going on that you're missing. If you're sort of having that feeling, it's probably a good thing to listen to, because it is a built-in way of your body to protect itself and you. So we know that any call can present a hazard, right? That just goes without saying. It could be something simple, it could be something pretty involved. But what do you think has the highest potential for those kind of threats?
Domestic violence.
Yeah, domestics are the worst. Even cops don't like going on those calls because anything can happen. What else though? I mean, that's the obvious one. What else do you think could go terribly, horribly wrong?
Like patient site calls.
Yeah, psych calls. Even some of the simple things like going to work and overdose. People are going to be upset. People don't often, make the best choices and come up with the best decisions when placed in stressful situations. So as much as it turns into something personal, it might not start out as, an actual personal thing like, they're mad at you. They might just be mad and acting irrational. So take a step back and don't lose yourself in the scene. So like I said, mechanism of injury, pretty straightforward, pretty easy. It is the actual forces that caused that injury. Now, mechanism of injury and understanding sort of the gravitational forces that caused those injuries can help us predict injury patterns. When we look at a vehicle that's been involved in a collision, we can actually look at the inside of the vehicle, look at the outside of the vehicle, and know the kinds of things that we can expect for injuries. If we open up the car and we look and we see that spouted windshield, what's that going to tell me right off the bat?
Possible head spine injury.
Yeah, I'm going to possibly have a head and spine injury because my patient's squash is what punched a hole in that windshield. So clearly they weren't restrained. This up and over injury pattern we'll talk about is, yes, the head comes up, hits the windshield and causes some head and cervical spine injury. But what else are they going to strike as they're coming up over the steering wheel?
Chest, abdomen.
Chest, abdomen, maybe bilateral femur injuries because they're getting propelled forward at the same speed that the car was going before it struck. So we could see some pretty significant chest and abdomen injuries. We could see some pretty significant proximal lower extremity injuries just because that car's going 40 miles an hour when it hits. That patient is going 40 miles an hour until they hit that windshield, until they hit the dashboard, until they hit the steering wheel. So they're going in hot, and it is really an opportunity for some pretty significant injuries to happen to the patient just based on things that they strike inside the vehicle. And we have pretty good success looking at that and figuring out what else could be hurt. Because if your head hits the windshield at 40 miles an hour, what are you probably not when I get there?
Conscious.
Conscious, alert, and making much sense. Then the down and under injury pattern. This is not quite as common because for the most part, people do wear seatbelts and airbags work appropriately. But this is years ago something that used to happen an awful lot when people weren't restrained. They'd wind up in a car accident and we'd show up and we'd be looking at the driver and we'd be approaching the vehicle, and then we'd realize that somebody was tucked underneath the dashboard. They actually would wind up way down on the floorboard, just all smashed up. Their knees would have struck the dash. Their face would have struck the dash. They have just ridiculous amount of obvious injury because they hit everything, again, at 40 miles an hour. Rear end collisions, we expect a whole lot of whiplash type injuries and things like that. You have also what's called a coup counter coup response in your body. It's when you get hit, your head gets pulled back and you have that neck injury. And inside your skull, inside your cranium, your brain first goes backwards and it strikes the back of your brain against the inside of your skull. And then when that momentum propels you forward, you get to a point where the seatbelt stops you. And as you stop, your brain is then again propelled forward and it hits the inside of your skull in the front. So you wind up with both frontal, anterior and posterior injuries to your brain because of that coup counter coup response to the crash. And last but not least, rollovers. Rollovers are a catch as catch can. Anytime a vehicle winds up upside down, injury patterns are wide ranging and completely varied. Anything and everything. Not to mention the fact that any of the stuff that is inside that vehicle, when it crashes and when it goes over, turns into a projectile. So not only are you going to hit all of the inside of the vehicle, and every time that vehicle hits something or rolls over, it's another impact and another collision. Then you have any of the things that are inside that vehicle being rained down on top of the occupants. So we see a lot of different injury patterns with a rollover collision. Here's some good definitions to know right here. A severe fall or a significant fall for an adult is 20 feet or more. For a child under the age of 15, we're talking 10 feet or more or greater than 2 to 3 times their height. So if you look at like an infant who's only 24 or 30 inches, a fall of only just a few feet is really a significant fall for them. Whereas an adult can fall from 20 feet, yes, they would still be injured, but we might not be quite as concerned, and the fall may have been 10 times as far. If we're responding to a fall, we have some important things to remember here. How high did they fall from? What did they land on? What part of them made contact with the ground first? And did anything interrupt the fall? Did they hit anything on the way down that might have either slowed them down or caused them to fall multiple times? Because every time they hit something and arrest and come to a stop, then they fall again and they hit the ground or they hit something else, and it winds up multiple injury patterns, multiple places get damaged because, well, the patient really, in the grand scheme of things, had multiple falls. If we're still talking trauma, low velocity injuries, so we're talking penetrations here. Low velocity injuries are anything that is man powered. So knives and things like that penetrate your patient are considered to be low velocity. The damage is generally limited to whatever area was poked. If you find a patient who's only got one stab wound, generally keep looking, because it is uncommon for someone to only be stabbed once. If somebody is mad enough and it's personal enough that they're going to put a knife to them, generally speaking, they poke them more than one time. So if you only find one, yes, we're going to try and address all of the wounds and all of the injury. But if you only find one, I would be suspicious. Moving on down the road here with penetrating trauma, we have medium velocity and high velocity. Medium velocity rounds or penetrating issues come from handguns and shotguns, and generally high velocity injuries are considered to be rifle type injuries. These injuries can be anywhere in the body. Any part of the body can actually be injured when someone is shot. Bullets don't always travel in a direct straight path, but anything the bullet passes through is going to be damaged. That bottom piece, cavitation, I will see if I can dig up the video that I have that depicts that pretty well. But if anybody out there ever seen like those ballistic gelatin tests, when they set up a block on a table and they shoot it with something, and then they slow-mo break it down, and you see this great big giant wound cavity open up.
Yep.
As that bullet is passing through the ballistic gelatin, that temporary wound cavity is caused by cavitation. It's the pressure wave of the bullet actually penetrating the tissue. The permanent wound cavity is what the bullet makes. But all of that cavitation, all of that pressure, like, liquefies and really damages the tissue that it passes through very, very much. So you may see just only a small hole, but there may be a ton of damage internally from that, quote, small hole. It's only small because it's in somebody else, I'll tell you that. Blunt force trauma is injuries to the body caused by, obviously, a traumatic event, because it's called blunt force trauma, but it doesn't actually penetrate the skin or the body tissues. Blunt force trauma is pretty tough sometimes because bruises don't always develop right away. Swelling doesn't always develop right away. Changes to the skin and changes to sort of what people feel like when we palpate them aren't always immediate and recognizable. It takes some time for those things to pop up. So it's easy to miss. That's why we maintain our index of suspicion based on mechanism sometimes. If your patient has been struck with some sort of blunt instrument, they're at work and something breaks and a pipe hits them in the chest or hits them in the legs, or, something big and heavy gets dropped on them, and you don't find injury, you should probably start asking yourself, why isn't this hurt worse? And the answer to that is just because it didn't break the skin doesn't necessarily mean that they isn't hurt worse, that the patient isn't having complications underneath that just haven't developed yet. Because all of that swelling and all of that bruising, it needs to have blood actually leaking into the tissue and causing that bruising, causing that tenderness, causing that rigidity to actually have that show up externally. People can bleed for a significant amount of time internally, and we never see or hear a thing until we start talking shock and the changes in our patients' sort of vital signs and mentation, and you start to see some of the changes that happen inside the body, and you go, well, all right, well, why isn't there anything external? And the answer could be that it just hasn't manifested yet. Nature of the illness, simple. What'd you call 911 for today? When I'm doing my scene size up and my primary assessment, which is what we're going to talk about next, pretty much the way I end all of this to get my nature of their illness is, hey, so how come I'm here today? What'd you call 911 for? You know, do it kind of conversationally, but it's giving me information. I am an information sponge. I want to know everything because I can't make informed decisions and clinical judgments unless I have the information that I need. Where and how can I get that information? Anywhere and everywhere humanly possible. I'll talk to the patient. I'll talk to their family. I'll talk to their maiden aunt Sally. I'll talk to bystanders on scene if anybody has anything useful. And then we have the scene. Again, we're still talking scene size up here. When you walk into somebody's house and you hear the steady kind of constant whoosh of an oxygen concentrator, and you look and there's oxygen tubing going throughout all the house, and the house smells like cigarettes, and you were dispatched for a respiratory call. 2 + 2 being 4, we're here to deal with a chronic respiratory patient who's now having some emergent type disease. You know, you look around, you investigate a little bit. Some of what we do is medical detective work. But constantly ask yourself, do I have enough resources on hand to care for this patient or any other that may arise? Now, having enough resources isn't always, like I said, calling in the fire department or the police department or electric, light, gas, whoever. Sometimes when we're evaluating a patient, we look at them very early on and go, wow, this patient's so sick, they might actually benefit from me getting a paramedic for them. Now, EMT is, you know, a great, great, great job. It's a great stepping stone and view into the medical field. But if you're going to remain in this profession for a while, there's other levels of provider that still operate in an ambulance, still have all the autonomy, still get to do all the cool things of the job, and they get to do more. We talked pretty briefly about the different levels of provider, and paramedic is pretty much top of the mountain. They can do all sorts of invasive and non-invasive interventions that we can't. They have just a plethora of drugs that they can provide, IV or IM, or however you might want to get a medicine into a patient. They can do it. They can intubate patients. They are great with cardiology and respiratory patients. So there's times where you look at a patient and go, whoop, they're really sick. Oh, this is definitely a cardiac. Maybe they need an EKG. Maybe they need some IV meds. Maybe they need some this. Maybe they need some that. And asking for a paramedic for this patient is probably best practice. That's not to be said that you can't care for them, though. When you're looking for an ALS level response and you want a paramedic to meet you with this patient, sometimes in this area in particular, your closest ALS provider might be the emergency room. So when you look at a patient and decide, wow, they're really sick, they need more than I can physically do at this very given moment in time, get your assessment done and transport that patient. Paramedics are in vehicles that have wheels too. If they can, they will meet you en route to the hospital. And if they can't, you still brought that patient to where definitive care lives. You still brought that patient to the emergency room where they are going to be put back together and cared for appropriately. And you still did what's best for the patient, and you still did what's best for you as a provider. So never wait on scene for a paramedic to arrive. If your patient's that sick, get your assessment done, get yourself packaged up, and get yourself out of there. All right, that is chapter number 9, part 1, the scene size up. I'm going to give you guys another short break, and we will do chapter number 9, part 2, the primary assessment. And after that, we will break for lunch. So let's take another quick 10 or so minute break. I'll put the timer up, and we will be back in just a few minutes.
Thank you.
Yep. All right, everybody, last and not least for this morning, we are going to talk our primary assessment. So up until this point, we have talked about the things that are vital to us in keeping us upright and taking nourishment. Now we're going to focus on those same things, but for our actual patient. Our primary assessment is going to take care of primary type problems. That means we are going to focus on the life threats. Now, we have added a piece to this airway breathing circulation module here. It takes, generally speaking, from an uncontrolled bleed, somewhere between 90 seconds and 2 minutes to bleed to death. If I'm assessing and treating my patient's airway problem, and then assessing and treating my patient's breathing problem, by the time I get to circulation and assessing and treating their circulatory problem, which is them bleeding all over the ground, they've already bled to death. So for airway breathing and circulation, we are going to put an X in front of that. And X stands for exsanguination. When we're focusing on our life threats and we're approaching our patient and getting ready to manage our life threats with airway breathing and circulation, we're going to look for life-threatening hemorrhage first. And that's not necessarily being able to see the particular bleed in question, but look for things that point you towards that your patient has one, and you'll know that, all right, this is what I need to address first. If you see, large puddles and pools of blood on the ground, or blood all over the wall, or blood all over the ceiling, it is time to fix that right this very second. Now, as far as hemorrhage control goes, we are going to talk about direct pressure first. And then, thankfully, over the last several years, there has been a switch, because we used to do all sorts of other nonsense in an effort to control life-threatening hemorrhage, and none of them worked, because everybody was taught years and years ago that if you put a tourniquet on somebody, you might as well have sawn their arm off. That is neither true nor appropriate. Now, when we are controlling life-threatening hemorrhage to an extremity, we are going to try direct pressure at first, and that means some pretty significant pressure in an effort to try and slow down that bleed. And if that doesn't work within just a few seconds, we're going to put a tourniquet on that extremity, period. No further questions. Tourniquets are not the voodoo magic that everybody thought they were years and years and years ago. It is the standard of care now that if we find a life-threatening hemorrhage during the beginning portion of our primary assessment, we are going to use direct pressure and then switch to a tourniquet in an effort to completely and totally stop that bleeding. We've found that if we let our patients continue to bleed, they wind up in shock, and they wind up pretty quickly in decompensated shock. That means their body is no longer sort of even involved in the battle, let alone winning it. So we manage those life-threatening bleeds right now. Then we move on to our patient's airway. Now, when we assess our patient's airway, we are assessing for patency. We want to make sure that that airway is open, clear, and secure. So yesterday we learned about the head tilt chin lift. Today we'll talk head tilt chin lift, jaw thrust. You guys all placed some of our airway adjuncts, the NPA, the OPA. We'll talk some more about those. When we assess our patient's airway for patency, and we make sure that it is open and clear, so meaning we apply some suction if there's blood or vomit or any other particulate in our patient's airway that needs to be removed, because our airway is the only way we get gas in from the outside, that ventilation we talked about yesterday. And without ventilation, there won't be any respiration. And without respiration, there's no energy creation. And without energy creation, we start to have a breakdown in this metabolic machine. So we make sure the airway's open. Either the patient's doing it themselves or we're doing it for them. Same thing with making sure the airway is clear. Either the patient is clearing their own airway or we clear it for them. And then secure. If our patient is conscious, alert, and speaking to us, they are maintaining their own patent airway. They are ensuring that their airway is open, clear, and secure. If we need to secure it, they get an OPA or they get an NPA. Once we have done all of that with our patient's airway, we move on to breathing. We are going to assess their respiratory rate, rhythm, and quality. And if we find problems with any of those things, we fix them. In assessing their rate, rhythm, and quality, we want to look at their breathing at this point and say, is it too fast? Is it too slow? Or is it just right? Rhythm means just that. Is it nice and rhythmic and regular? Or are there patterns of apnea? Or are they just breathing in a funny manner? And quality, we're going to listen. We're going to expose our patient's chest when we do our breathing assessment. And we're going to listen to those lung sounds that we talked about yesterday. In order for us to determine that our patient's rate, rhythm, and quality is good, breathing needs to be noiseless, effortless, and painless. So we need to make sure we verify all of those things. If we find a problem, we fix the problem. Then we move on to circulation. We're going to, in a conscious patient, check a radial pulse. That's going to tell me, is my patient's heart rate too fast, too slow, or just right? Because for circulation, we're also assessing rate, rhythm, and quality. So rate is it too fast? Is it too slow? Is it just right? Rhythm, same as with breathing, is it nice and rhythmic and regular? Or does it sound like there's a drum solo or feel like there's a drum solo going on when I check my patient's pulse? In quality, is it nice and strong and firm and I can feel it very good in their radial artery? After we assess circulation, we're going to take the back of our gloved hand and touch our patient. We're going to try and assess their skin, color, temperature, and condition, because that's going to lead us towards how good our patient's perfusion status is. Remember, perfusion is the adequate supply of oxygen and glucose so that the cells can create energy. People, as a general rule, regardless of skin pigmentation, we expect certain areas to be pink, warm, and dry. When you look at your patient's nail beds, or if you pull down their eyelid a little and you look inside their eyelid, or if you look inside their mouth, those are areas that on every single person should be pink. People should not feel cool to the touch. People should not feel hot to the touch. It should just feel like you're touching something when you touch someone whose skin temperature is regular. And condition, we want dry. People shouldn't just sit in their easy chair in their living room and sweat like a farmyard animal. People should be pink, warm, and dry. That is the last piece of our circulatory assessment. And then we do one final sweep for blood. We're going to take our gloved hands, especially in a patient who's laying supine, and we're going to stick them underneath our patient a little bit and pull them out every time and look at our gloves to see if they have any blood on them. If it's a significant amount of blood, we make it stop. If it's just a little bit of blood, that's a secondary problem. We'll deal with that during our secondary assessment and our patient treatment times. Airway, breathing, and circulation. If you find a problem, you fix the problem. Now, all of these things may vary depending on the patient's condition, other resources on scene. I think it was Paul that asked, if the situation becomes unmanageable and you need to get out of there, do you try and hoist the patient out with you? If we got to go and I can manage to drag that patient with me, maybe some of this stuff goes to the wind for a minute while I escape and evade with my patient. Or maybe my patient just stays there and me and my partner run away. There are some times where some of this stuff is open to interpretation. There may be times where your patient airway or breathing or circulatory problem is so bad that you never get any further than that step. If you have to hold a jaw thrust on your patient to maintain their open airway, well, guess what? That's the job that you bought. You never get any further than airway. If you get to breathing and find that your patient is apneic or not breathing at all, or breathing so ineffectively that you have to give them rescue breaths, 1 breath every 5 or 6 seconds with a BVM, again, that's the ticket you bought, so you'll be maintaining their breathing. Somebody else takes over the rest at that point. Our primary assessment begins as we're approaching our patient. We're going to form our general impression as we approach. We're going to start to assess our patient's mental status. In assessing our patient's mental status, we're going to look at some things. We want to use that AVPU scale. Generally speaking, when strangers in emergency uniforms show up in somebody's living room, normal mental status reaction to that is to look in that direction. If your patient doesn't actually look at you and make eye contact as you approach, they have an alteration in their mental status. Assessing the airway, we talked about. If your patient's talking to you, you can determine that the airway is patent. Assessing breathing, rate, rhythm, and quality. Assessing circulation, rate, rhythm, and quality. And then this last little piece here, determining patient priority. Here's the end of your primary assessment. Now we've completed scene size up. We've gotten to the end of our patient priority. Have we really asked this patient many questions or gotten a really good history from them, talked about, their medical complaints and the medications that they take and checked any vital signs or done anything really?
No.
No. So how do we determine a patient priority here? Anybody?
You
Take a
don't?
shot at it.
I mean, if there's one patient, then that's the priority. But I guess if one person is rougher shaped than the other, that person takes priority over the other.
All right. And in that situation, you're absolutely correct. But this is, now we'll just assume that we only have the one patient. This is priority for treatment and transport of just a single patient. How can
Would
we
you contact ALS?
We'd contact ALS at this point if we needed them for sure. But how do we use just these, these 5 things? How do we use that to determine our patient priority?
Well, you're basing it on what you've already observed as opposed to the complaints of the patient, and based on that, you decide whether or not you're going to stay and treat there and get them more stable, or if you just get them in the back of the ambulance and go.
Absolutely. So remember, your primary assessment is to determine and treat any life threats, immediate life threats. So if you found a problem with your patient while forming your general impression, or assessing their mental status, or assessing their airway, or assessing their breathing, or assessing their circulation, when we get down to the end of this and start determining our patient priority, does it hold water at that point that you have a sick patient staring back at you? You've managed life threats at that point, right?
Yes.
Yeah. All right, good. So if you've managed a life threat, your patient is a high priority patient. You're going to bring them to the closest appropriate facility and you're going to contact ALS and try and intercept en route. That is your patient priority. They're a high priority patient. We're going to bring them to the closest appropriate facility, and we're going to look for an ALS intercept en route. Our general impression is going to give us some input into the patient's chief complaint, their appearance. We're looking at the environment. We're, looking around. Does it smell like cigarettes? Is the house really like unkempt and is in a shambles? Is there rotted food all strewn all about the place? It's generally just telling us how our patient's average every day is and what's going on with them at this moment in time to make it different. General impression really is a look test. You kind of get a feeling from the environment. You kind of get a feeling from the patient. We can look at Grandpa laying right here on the ground and say, is that normal? Just ask yourself that. Is this how people should be found? If he
No.
was having a good day, he'd be sitting on the couch. He's laying on the floor. People don't just generally just walk across their living room and decide, this is where I'm going to lay down and lay down on the floor. So he doesn't pass the look test. So your general impression at this point is poor. Some other things that will indicate that your general impression of this patient's not so great is an altered mental status. If they have sort of this untenable feeling of anxiety, when you're looking at them as you approach, if they look any colors or any skin color, temperature, condition other than pink, warm, and dry, so sort of pale or, just sweating profusely and they look moist, or maybe you see some cyanosis, that's going to tell me my general impression of this patient is they're sick and maybe waited a little too long to call 911. If you see any obvious trauma to the head, chest, or abdomen, or pelvis, these are all areas that either A, house very important structures, or B, can maintain a lot of free-floating blood from internal hemorrhage before we see any actual bleeding. If we approach and our patient appears lifeless, we're going to begin resuscitation efforts. We talked about those yesterday when we did CPR. We're going to come down. Larry, are you okay? And if Larry doesn't respond, we give Larry a little pinch. And if Larry still doesn't respond, we call him unresponsive. And then we put 2 fingers on my patient's carotid pulse and my hand on Larry's chest. And for 5, no more than 10 seconds, I'm going to check and see, do I have any breathing? Do I have a carotid pulse? If I don't, we begin CPR. We're going to work cardiac arrest management at this point. We're going to prepare and apply the AED. We're going to turn that AED on. And then once that AED has been turned on, we listen to the squawky little machine that's sitting on the floor next to us. We look at the patient, trying to determine their age, their sex, any body positioning that looks sort of weird or out of sorts. We're going to listen to their breathing as we approach. Do we hear any more moaning? Do we hear any snoring that we can correct with an OPA? Do we hear any gurgling from their respirations that maybe we need to apply a little suction? This is all starting to form the picture of what's going on with this patient. Do we have any noxious smells like fumes or urine or feces or vomit or even decay? It is possible that your patient could be dead in their house for long enough that they start to begin the process of breaking down. We'll ask our patient about their chief complaint. Why'd you call 911 today? How did we come to meet this afternoon? They may tell you something absolutely spot on specific. I have pain right here and it hurts when I do this. Okay, cool. Or you may get the very vague complaints of, I just don't feel right. Or, I'm feeling awful tired lately. You don't know what you're going to get when you ask that question, but whatever the patient tells you is their chief complaint. Our airway assessment, we use that AVPU scale. Are they alert? Do they look at me when I approach? If they don't, and I have to yell, Larry, Larry, and then Larry kind of snaps to and looks at me. Or I yell, Larry, Larry, and he does nothing, and I have to try and elicit that painful response. Or I give him a pinch and he still does nothing. I call Larry unresponsive at that point. After I have determined whether Larry is alert, what I've gotten from that is, are the lights on? Now I have to know, is Larry oriented? I have to know now, not only are the lights on, is somebody home? So I want to ask Larry 4 questions if he's alert. I want to know if he knows who he is. I want to know if he knows where he is. I want to know if he knows reasonably around what time it is, beginning of March. It's Thursday at 11:15. And I want to know, does he know what's going on right now? So person, place, time, and event. If Larry answers all of those questions appropriately, I mark him as conscious, alert, and oriented times 4, because he's now not only alert, he is also conscious, making sense, and is oriented to person, place, time, and event. If he's not oriented to one of those things, then he's conscious, alert, and oriented times 3, and I mark which one he got wrong.
I have a quick question.
Shoot.
If someone say calls for, like, is it, I don't know how to word it. So say there's a person that's suicidal and calls 911. Would we show up to that call, or would that be something more out of our hands because they didn't hurt themselves yet, but obviously it's a mental issue. So would we direct them to, like, we'd still show up, right?
Yep. Not only that, we'd transport. If somebody calls 911 with SI or suicidal ideations, at that point, they're probably going to wind up on that section 12 that we talked about and wind up involuntarily transported to the emergency room. Sometimes they'll go willingly. They called 911 looking for help. Police are probably going to show up. Fire is probably going to show up. We are going to show up. And eventually, whatever is best for that patient is what's going to happen next.
Right. But say someone, like, they call 911 and they're suicidal, and we get there and they're gonna commit suicide, and that's out of our hands at that point, and they have like a dangerous object, or like are standing on the side of the house or something like that and gonna jump. That's the police's.
Yeah,
That's
that'll
police.
be police and fire until that whole situation piece of it is managed.
Right. But if we're the first ones there, we try to calm them do we calm them as much as possible, or do we, because it's a dangerous situation, do we even go in? Like, I mean,
A little from column A, a little from column B. If your patient is, standing out in the front yard and, maybe they don't present a threat to you. Maybe they do. If they do, all right, I'm going to stay away from that. I'm going to park my ambulance down the street. Whatever happens in the meantime is what happens in the meantime. If my patient doesn't present a threat to me, I'll try and talk them down and try and work with them and try and convince them to come and get the help that they called for.
mhm.
So our airway assessment during primary assessment is pretty cut and dry. If the airway is not patent, if it is not open, clear, and secure, we are going to take measures to fix that. You can see some suction being applied here. If we don't have any signs of trauma on our patient and we need to open their airway, we're going to use that head tilt chin lift that we talked about during CPR yesterday. If my patient has been victim or looks like they've been victim of a trauma, we're going to use the jaw thrust to open their airway. You actually put your hands on the bottom pieces of the mandible, those points of your jaw, and you're going to pull them up forward anteriorly to the front of the patient's face and use your fingers to hold that airway open. That's going to require both hands. You are locked in at that point until somebody else relieves you and does a jaw thrust for you. We will put in OPAs, we will put in NPAs, we will apply suction as necessary. That's how we make sure that airway is not only open, clear, and secure, but remains that way. A patient may need some assistance breathing. That's when we will do those rescue breaths, that one breath every 5 or 6 seconds. Some things that will absolutely dictate to you that you'll be breathing for this patient are respiratory arrest. Anytime arrest is involved in a word that has to do with medicine, it means they're not doing it anymore. So this patient in respiratory arrest is not breathing at all. A patient who's not really alert, not answering our questions appropriately, and has some signs of inadequate breathing, or some alertness but signs of inadequate breathing, or maybe it looks like their chest is going up and down adequately, but we notice that they're having some signs of poor perfusion or respiratory distress, or we start to see some of that cyanosis now maybe spreading from just around their lips and their fingertips to more centrally, more close to the midline areas on their body. Well, clearly their body is not adequately providing for its needs at that point, and they are in respiratory failure. Remember, failure means the body is no longer providing what it needs to remain a viable human. So we already talked about this a little bit. We're going to assess our patient's pulse during our circulation check. We want to look at, is it too fast? Is it too slow? Is it just right? Is it nice and strong, or is it kind of weak? If they do not have a pulse, obviously we're going to begin CPR. We assess that skin color, temperature, and condition. I can't stress how important checking for a quick set of lung sounds and assessing your patient's skin color, temperature, and condition, how important those things are, because they will tell us a just litany of information in a short amount of time. We're going to assess bleeding again. We're going to do that, I call it the sticky test. You put your hands underneath your patient and see if your gloves come back sticky. If they do, how sticky are they? These are the 3 results we get when we're assessing our patient's rate, rhythm, and quality of their pulse. Too fast and irregular, too fast and regular, too slow and irregular, too slow and irregular, or within normal limits. We're going to go ahead and check that pulse. We're not really interested in a number at this point. You're really just looking to see too fast, too slow, just right. That skin color, temperature, and condition, good circulation, good perfusion will mean pink, warm, and dry. If your patient is not pink, warm, and dry, we have probably some sort of respiratory problem, but definitely some shock, possible perfusion issues. If they are pale, cool, clammy, diaphoretic, moist, you name it, it's pointing you down the path of this patient is very, very critically ill. As soon as we find our patient with an airway, breathing, circulation problem, a patient who we weren't happy with our general impression, a patient with an altered mental status, we want to start working our way through those problems the minute that we identify them. So that is the absolute rule for all of this. If you find a problem during your primary assessment, you fix it. Because stable means we didn't find any problems with our primary assessment. Unstable means we had threats to mental status, airway, breathing, and circulation. That doesn't mean that my patient can only be stable or unstable. We could find some things that make us unhappy with maybe the way our patient presents or the way our patient looks, so our general impression is not great. But they're still maintaining their own airway. They're still breathing adequately. They still have adequate circulation. So they are potentially unstable, and we need to dig a little deeper. That's why this is only the primary portion of our assessment. After this, we're going to get into their medical history. We're going to get into their current history of their present illness and figure out what is it that is actually going on with this patient and how sick are they. Right now, primary assessment, primary problem. Primary problem means I fix it the moment I find it. We're going to initiate priority transport if we found any life-threatening issues and things that we can't control or are recurrent. We move that patient PDQ in a hurry, and we continue everything else en route. when you have a critically ill patient or a critically injured patient, hanging around on scene is not the order of the day. Now, there are some times where we can treat some things on scene and maybe make our patient a little bit more comfortable, but not when we find primary issues, not when we find immediate life threats that need to be fixed right away. Sometimes we make some allowances for differences in assessment based on our patient. Are they a medical patient or are they a trauma patient? We're going to do, it's really close to the same steps to assess a trauma patient as it is to assess a medical patient, but our trauma patient is going to be a bit more of a hands-on assessment, where our medical patient is somebody we're going to ask a lot of questions. We may have to change the way we do things a little if my patient's altered. You know, they may not be able to answer the questions that I'm asking them, and I may have to do more of a physical exam. We do things in a little bit of a different order when we're talking pediatrics versus adult medicine. Kids sometimes are made uncomfortable by our presence alone, and we may need some help, or we may need to work a little differently. And all of these things are well within bounds and well within our scope to do. Remember from CPR, we're going to check a brachial pulse on infants. They got those pudgy little necks where we would never probably successfully find a carotid pulse, no matter how hard we tried. So take your 2 fingers right above the humerus and reach in where their bicep would be, and you'll be able to feel that brachial pulse. Not only do we follow just the steps of our primary assessment methodically and systematically, your assessment should always be done in a methodic and systematic manner, but especially with our primary assessment, because your primary assessment is going to identify things that are trying to kill this patient right this very second. All those immediate life threats are things that you're going to deal with as soon as you find them. And if your patient has a poor general impression and has a bit of an altered mental status and has some problems with airway, breathing, or circulation, we make them a priority patient. We bring them to where definitive care lives as soon as possible, because getting those life-threatening issues corrected and turned around and heading in a more positive direction is going to be the best patient care that we can provide for them. It just is. So what do you guys think of some things you'd consider when you're forming your general impression of a patient? What are some things you would look at and things that would make you kind of maybe go, this doesn't seem like it's a good thing?
Their positioning.
Their positioning, sure. There's certain positions that a patient will sit in just to make the act of breathing less difficult. There's certain patient positions that they will sit in because they're having intractable abdominal pain. That means abdominal pain that can hardly be relieved or maybe can't be relieved. And they're not normal anatomical, regular physiological ways for a person to be found. So if you do see certain things as you're approaching and making your general impression, you haven't touched this person, you haven't talked to this person, you haven't done a single thing, but you can look at them and go, wow, they don't look quite right. So we're going to have to really get on about our business of figuring this out and making sure that we make them a salvageable person. We did AVPU already. Let's see, one more set of questions. How should you assess airway, breathing, and circulation during your primary assessment? What are we going to do?
Check the lungs for breathing.
Okay.
Look, listen, and feel.
I like it. Look, listen, and feel. Let's use as many of our senses as we can to get a pretty good idea of what's going on. So we're going to look at their chest rise and fall. We're going to listen to those lung sounds. We might actually put our hands on our patient to make sure that that rib cage is traveling as much as we need it to get adequate gas moved around. The same goes for their airway. So we'll start right at the beginning. We're going to look for gross hemorrhage right off the gate, right off the bat. Our airway, we look, do we see anything that is maybe making it unmanageable? We're going to listen. Do we hear any adventitious noises? Do we hear anything that make us concerned about our patient's airway patency? Okay, if we do, we fix it. If we don't, we move on. Breathing. We're going to look, listen, and feel. We're going to get that rate, rhythm, and quality. We're going to move on primary assessment. And if we found a problem with breathing, we fix that problem with breathing. Same goes for circulation. When we look, listen, and feel, we are going to touch. We're not necessarily doing a whole lot of looking, but we will look and see, does this patient appear lifeless? Because respiratory arrest is a whole lot different than cardiac arrest. And they generally follow one another pretty closely, but it is a possibility that your patient may appear lifeless and still have a pulse. So we need to make sure we are really working our way through all of these steps to form our general impression, get our mental status, assess for life-threatening hemorrhage, because it would be kind of crummy to get all the way through all of that and get to circulation and realize that they have poured their circulating blood volume onto the floor, and now there's not a blessed thing you can do for them. So after we figure all that out, we move on to airway, breathing, circulation, go through all the steps, do all of the things that we're going to do, and then we make our priority decision. If at any point your patient has not successfully made it through the forming of your general impression, your mental status check, you'd look for gross hemorrhage and extreme bleeding, your airway is not patent, it's not open, it's not clear, it's not secure. You had to fix that. Okay, that's a problem. Breathing, we check that rate, rhythm, and quality. We look, listen, and feel. We get that quick set of lung sounds that'll tell us a lot. If we found a problem, we fix the problem. Circulation, same deal. Rate, rhythm, and quality. I want to know, too fast, too slow, just right. Is it regular? And is it easy to feel? That's my quality. And then from there, we move right along to making our transport priority decision. And I'm going to give you guys a hint right now in class, right? In class, you are going to put every patient on oxygen, and we'll talk more about that when you get here. Also, in class, get used to saying the words, my patient is a high priority transport. I'm going to bring them to the closest appropriate facility, and I'm going to arrange for an ALS intercept en route. Because that is the end of your primary assessment for all of your testing stations, period.